Case number 1, I think young patient with malnutrition. This is from the duodenum. See here, villi are gone, okay, and there is crypt hypertrophy. And when you enlarge the image, you can see the intraepithelial lymphocytes. These are known as intrathelial lymphocytes. So these are the 3 criteria for the diagnosis of celiac disease: villus atrophy, crypt hypertrophy, and increased number of lymphocytes in the lamina propria and attacking the epithelium, which are known as teliolymphocytes. Okay, epithelial lymphocytes are known as teliolymphocytes. So the first case is celiac disease. Case number 2, again a pediatric patient, I think, malnutrition, I think, history, poor weight gain. These are biopsies. In the low power, you see the uniform distribution. Normally, all the glands are uniform size, shape, distribution, SSD. And whenever you see a dropout, here you can go for deepers and you can get, because you see it on the surface, you see it on the base, because of the orientation here, the glands are not there. But when there is a real loss, that means it is a chronic colitis. When there is loss of glands or irregular size, shape, distribution of these glands, then it is chronic colitis. By definition, patient should have 6 months of symptoms, and morphologically there is a disturbance in the gland number, distribution, size, and shape. Super. When you go to this picture, this is from the colon. Can you all see fuzzy material? It's like cilia or microvilli. When you see them, you have to think of microorganisms sticking to the surface. And this is a nice case of spirochetes. So this is a very, and when you do silver stain or IHC, you can very nicely see the organisms. And any biopsies, you have to have a systematic view. Look at the lumen, then to the surface, then to the lamina propria, then to the submucosa if present. That systematic approach is very, very important. Slide number 3 is a low power diagnosis. If you go to the high power, you will get confused. So this is a 56-year-old male, pain in the left iliac fossa. And this is the epithelium. You see the epithelium going down and ruptured. Some inflammation is happening and it is opening into the serosa. So this is a diverticular process where the epithelium is going through the muscularis propria into the serosa, and it has ruptured and inflamed. So this is a ruptured diverticulitis, acute diverticulitis with rupture, more common on the left side because of the constipation or increased pressure in the lumen. Case number 3 and 4, I think it's full thickness. Remember, I told you you have to go through systematic approach. Okay, in a biopsy, it is surface, lamina propria, and then the crypts or the glands. In case of full section, then you have to go to the submucosa, the muscular layer, and then the serosa. Whole thickness is involved. Mucosa, submucosa, muscle, serosa involved. And serosa is extensively inflamed, and you cannot see any viable tissue. When you don't see any viable tissue and it's full thickness, think of infarct. Okay, so this is ischemic colitis. And ischemic colitis, depending upon the layers involved, it can be mucosal and submucosal ischemia or transmural ischemia. Here, this is a best example of transmural ischemia. And whenever you see transmural ischemia, 2 things are important. What causes this ischemia and what happens to the margin? The margin has to be viable. If the margins are also showing ischemic change, call the clinician and tell them. Because of the anatomic restrictions, they may not be able to remove the whole ischemic colon. So, but it is our duty to tell them. And the second thing is what causes. Is there any thrombus in the mesenteric blood vessels? Very, very important. You have to see any thrombus here. And if there is any thrombus, it should be away from the ischemia, because the ischemia itself can cause thrombosis. Whether ischemia causing the thrombosis or thrombosis causing the ischemia is the question you have to ask for. So that is slide number 4. Coming to slide number 5, it's a 43-year-old male, fever and diarrhea. So this is a straightforward diagnosis. You can see nice volcanoes. And you see the preserved crypt epithelium at the base. Only superficially it is destroyed and it is showing fibrinopurulent exudate. So this is pseudomembranous colitis on a biopsy. And next case, I think case number 6 is also pseudomembranous colitis, but this is a resection specimen. Here you can see a lot of edema. The mucosa, some abnormality is there. There is some ulceration. Submucosa is very widened by edema. Muscle is there, and there is serosa. recently last week I saw a case where there is total ischemia along with some membranous area. Whenever there is total ischemia with membrane, you have to think of ischemic colitis. In pseudomembranous colitis, transmural ischemia may not be present. Remember, I showed you the crypts which are preserved. Even here, you can see the mushroom shaped fibrinopurulent exudate. But when you go down, the crypts are preserved. So when the preserved crypts with the fibrinopurulent exudate, you have to think of pseudomembranous colitis. And another point I forgot to tell, whenever you see ischemia anywhere in the organ, look for CMV infection. Because as you all know, CMV affects mesenchymally derived cells. So they affect the endothelial cell and fibroblast first. And when they affect the endothelial cell, it produces endotheliitis and vasculitis and thrombosis. And that thrombosis causes ischemia. So whenever there is ischemia in any organ, look for CMV in the blood vessels, in the endothelium. This history I close. Some nodularity, maybe a polyp in the colon. You can see the nice colonic mucosa, uniform size shape distribution, nothing in the lumen. We will go to the high power to go to and see the surface epithelium, lamina propria. And in the submucosa, there is a big mass. And when you go to the high power, they are made up of spindle cells. And these spindle cells are coming out of the blood vessels. And whenever you see spindle cells, you have to think of GIST. But GIST is a immunohistochemical diagnosis. It is not a H&E diagnosis. So whenever you see spindle cells, there are few things you have to remember in spindle cell neoplasm. Number one, what is the junction between the normal? So it is well circumscribed. Number two, cellularity, hypercellular or hypocellular. This looks like hyper and hypocellular. Number three, cellular atypia. Here it is not present. Number four, mitosis, not present. Number five, necrosis and hemorrhage, not present. So this is a low-grade spindle cell lesion. And look at them, they are coming around the blood vessels. And you all know blood vessels are having smooth muscle bundle. So this is a nice case of leiomyoma. The only negative thing here is it is there in the margin. So you have to tell the clinician it's a benign leiomyoma and it is present in the margin. Whenever it is present in the margin, it may recur. Chances are less because this is a benign condition. But because of the incomplete removal, it may regrow. That you have to tell the clinician. So margin, cellularity, atypia, mitosis, necrosis. And when there is mitosis, what is the number in 10 high power field? Is it typical or atypical? Because even if you see one atypical mitosis, it is malignant. And another important thing, next two slides are also submucosal. And whenever there is a submucosal lesion, if they take the biopsy from the mucosa, it will look normal. But if you are not taking from the lesion, we cannot give the diagnosis. Here you see the another biopsy. Again, history doesn't matter for this case. But here you see the lamina propria very irregularly distributed. See the lobularity of the submucosal glands. This is the lining epithelium. Most of them are sloughed off. These glands, they are all grouped. And these are divided by some stromal proliferation. Something is happening in the stroma. And this is nothing but neural proliferation. And if you go to the high power, there is one more thing you can zoom. I want to show the ganglion cells. So, yes. Can you all see the ganglion cells? Dr. Sharon, Ram?
So,
ganglion cells, okay? Neural cells, ganglion cells. So, this is ganglioneuroma. And when do you suspect that? Remember, I told you, normal colonic mucosa should have a uniform size shape distribution. Here, the distribution is gone. They may be uniformly sized, but the distribution is gone. And there is clustering of these glands with the expansion of the lamina propria in the low power. And then you go to the high power. Case number 9. Again, this is a excision, 45-year-old male, incidental finding in a colon. And you can see nice lesion in the subepithelium. And it is clear, nothing in the lumen, uniform size shape distribution. Muscle is normal, serosa is normal. So when you go to the high power, this is submucosal lipoma. And it's a low power diagnosis. And I always tell my PGs, don't put the slides directly under the microscope. See the section like this with your gross eye before putting it. The minute you see this lesion, you know where to go and concentrate. And you most of the time you can make, for example, the diverticular is also, you can take a, when you see the full mount section, you can make the diagnosis. So without seeing the full mount section, don't go to the microscope. See it in your naked eye. This is another lesion, another nice submucosal lesion. And when you go to the high power, these are lot of spaces, and these spaces, some of them are having RBCs, some of them are having inspissated serum, and they are all lined by endothelial cells. So the differential diagnosis here is it hemangioma or lymphangioma? When you, in case of lymphangioma, you never see RBCs in the lumen. And other thing, you see lot of lymphoid cells in and around the lesion. Whereas in hemangioma, you see the RBCs and you don't see that much of lymphoid cells. And who cares? What is the impact on the patient? Whether you call lymphangioma or hemangioma, it is the same. So don't do immunohistochemistry. Some people do D240 to prove it is lymphangioma. But to me, today, it is not necessary. Tomorrow, it may be a different picture. Case number 11. So this is the mucosa, this is the serosa. The tumor is through and through the section, and it's more like spindle cells, hypercellular. It's relatively well circumscribed. I don't see any cytological atypia. I saw mitosis just 1 or 2 per 10 high power field. There is some areas of hemorrhage and necrosis are there. And whenever there is hemorrhage necrosis, you have to see it grossly and you have to give the, what is the percentage. If grossly no hemorrhage and necrosis, you see microscopically, give it in this slide. For example, here I will give 25% or 30% hemorrhage and necrosis. And again, spindle cell tumor, it's never call any spindle cell lesion benign. Either it is low malignant potential or high malignant potential. This is c-KIT positive, DOG1 positive. And remember, there is a table in the CAP protocol that differentiates whether it is in the location, stomach, duodenum or colon, small intestine or colon, what is the size of the lesion, what is the atypia, what is the necrosis, low malignant potential, intermediate malignant potential, and high malignant potential. And you please believe me, this is a low malignant potential after applying all the criteria. Case number 12. And even though it looks polypoid here, the main lesion is here. See here, the glands are uniformly sized, shaped, distributed. See how nicely they are uniformly sized, shaped, and distributed here. And when you come to this side, start seeing the serration. And see, rather than standing, the glands are started lying down. Even if you see, according to WHO criteria, even if you see one gland lying parallel to the submucosa or the muscularis mucosa, it is sessile, serrated, lesion, or polyp, or adenoma, depending upon what all the things. If it is a polypoid lesion, you can call it as sessile serrated polyp. If it shows adenomatous epithelium also, you can tell it sessile serrated adenoma. But when you see neither the polyp nor the adenomatous epithelium, that's why they termed the or coined the terminology sessile serrated lesion, because there is neither polyp nor adenomatous epithelium. I want to go in the high power to show you the serrations. I hope you all can see the serrations here, and abnormally located, boot shaped. If it is connected with here, this is more like roughly boot shaped, but there is no dysplasia. So this is a serrated, classic serrated polyp, so or sessile serrated lesion. Okay, slide number 13. So this is a polyp. You see some dilated spaces, okay, irregularly dilated spaces, cystic spaces filled with mucin, lot of areas of hemorrhage. And whenever you see cystically dilated polyp arranged parallel to each other, you have to think of juvenile polyp. What happened here, that juvenile polyp has undergone torsion and infarction. That's why you don't see any surface or any structures lining these cystic spaces. And you see only mucin. And if you go to the highest power, you can see disintegrated epithelial cells because of the torsion. So this is a juvenile polyp with the infarct or torsion. Slide number 14, again low power diagnosis. Villus adenoma. Anybody should diagnose this villus adenoma. But whenever you see villus adenoma, remember that 25 to 75, more than 75 villus adenoma, 25 to 75 villus structures, tubulovillus adenoma, less than 25% of villus structures, tubular adenoma. And the next thing you have to see is whether there is high grade dysplasia. Adenoma per se, it is a dysplastic epithelium. And how do you say it's a dysplastic epithelium? There is 4 criteria: stratification, loss of mucin, apoptosis, mitosis. Remember, the gastric colonic and gastric and all the GI epithelium are single layered. For example, here somewhat preserved, single layer. Whereas when you call it adenomatous epithelium, they will show stratification. So, and when they stratify, the goblet cells become less in number. So, loss of mucin or less of mucin, and there will be a lot of mitosis or apoptosis. You can see these are all the apoptosis. When you see all these 4, stratification, loss of mucin or less of mucin, apoptosis, mitosis, it is adenoma. And when do you call low grade and high grade adenoma? In low grade adenoma, the stratified nuclei won't reach the top. It will stay in the middle third, and they all run towards, they are all pencil shaped. Whereas in high grade dysplasia, they reach the top, they are all round with a prominent nucleoli, and there will be loss of polarity. They may not be running in one direction, they will be running in different directions, and architecturally they will form micropapillae and cribriforming. In the low power, you can see this area. See how nicely there is cribriforming here in the low power. If you go to the high power, you can see cribriforming. Some people say this is a back-to-back gland arrangement. I don't agree with that. It is not, this is one gland, this is one gland. This is not back-to-back gland. This is one single gland with the intraglandular growth. They start like papillary projections. And when these papillary projections join each other, they form cribriforming. And you can see the nuclei reaching the top of the thing. And you can see the loss of polarity. Look at this nuclei running in this direction. Look at this nuclei running in this direction. How do you assess polarity? Draw a line along the long axis of the nuclei. They should be parallel to each other. For example, here they are more parallel. So here the polarity is maintained. Whereas here they are running in different directions. So the polarity is lost. Case number 15. In this low power, you can see the tumor here. Normal epithelium here, abundant supranuclear mucin. And when you do immunohistochemistry, the mucin stain will be positive above the nuclei and neuroendocrine markers will be positive below the nucleus. So this is a ampicrine tumor where same cell having epithelial and neuroendocrine features. And if you remember, this is a intermediate grade menin. Mixed epithelial, mixed endocrine, non-neuroendocrine tumor, goblet cell. Previously called goblet cell carcinoid. Now the new name is goblet cell carcinoma. It is not carcinoid. Slide number 16. Another interesting slide. This is from the colon. You can see the mucinous epithelium and the normal mucosa and dysplastic epithelium. So here you can see the normal mucosa. Again, some of the mucosa are not stained very well. Let us go to the tumor, and it is showing pools of mucin with the cells floating in up. So this is mucinous carcinoma. And one more interesting thing, see the black dots, pigments. They look like anthracotic pigments. What happened here? When we saw this, we called the clinician and they told this patient has previous endoscopy. They removed a polyp. At the time of polyp removal, it was looking very abnormal. So they injected some India ink tattooing. And that India ink tattooing you can see in the excision. So this tells you whatever you see in pathology, try to explain. Don't ignore anything. 17 from the colon, from a big mass. And it's predominantly tumor. And you can see a entrapped epithelium. This is small blue cells. They are looking basaloid and they are looking peripheral palisading. Peripheral palisading, you can see it in high power, nicely seen. And they show some comedonecrosis. When you see blue basaloid cells with the peripheral palisading and DCIS comedo type of necrosis, think of basaloid carcinoma. Now the terminology is not used. It's undifferentiated carcinoma in the colorectum, but the comedonecrosis and the peripheral palisading very, very important because this has a very bad prognosis. Slide number 18, again whole slide. You can see the mucosal surface, submucosa, muscle invaded by tumor, and you can see the serosa. Here you can see some conventional adenocarcinoma. There is no problem in that. Moderately differentiated adenocarcinoma NOS. But when you come to this area, there are solid nests that are secreting mucin and they are clear cells. And there is adenocarcinoma colon with a clear cell features. And these tumors are very rare. They don't know what is the prognostic significance. In those cases, please see adenocarcinoma NOS with the clear cell features. Always quantitate. For example, this is the only area where I see clear cell features. I may call it 40%. So in future, they may come up, they may example all these, they may examine all these cases, and they may come up with some useful information. 19 is a very, very easy case. Everybody should have made the diagnosis. It's a RT lesion. This is from the anal canal. And again, seeing it whole mount is very, very important. So you can see the verrucous or verrucomatous lesion, but the margins are very nicely there. They are not pushing margin. So it is not a verrucous carcinoma. So it is a condyloma acuminata. And when you go to the high power, you can see nice coilocytes. See the coilocytes, beautiful, isn't it? So nice coilocytes. And for verrucous carcinoma, you should not see coilocytes. Verrucous carcinoma, not HPV related, no coilocytes. So here it is more thin, and that much of coilocytes are not there. And there is some loss of polarity, atypia is seen, mitosis is seen higher up. So this is a high-grade dysplasia arising in a condyloma acuminata. Slide number 20, very easy case. This is from the anal canal. This is the transition from the anorectal area. You can see the big muscle bundles, and you can see in the whole mount the lesion is here. Normal colonic mucosa is there, and when you come to the high power, the solid nests are showing squamous differentiation. So this is a squamous cell carcinoma, moderately differentiated. See, that's why I hate the three-tier system. When it is mild, moderate, severe, everybody will stay in moderate. So that's why I love low grade and high grade. This lesion, I will call it high grade in two-tier system and moderate in three-tier system. To call it well differentiated, I want to see squamous epithelial pearls. There is a lot of individual cell keratinization is there, but I don't see nice epithelial pearl. Epithelial pearl should be there to call it as well differentiated squamous cell carcinoma.